Hello all. Today we are going to discuss about the next topic, that is odontogenic infections following dentoalveolar surgery. We know what are dentoalveolar surgeries, right? Which are dealing with the surgical area of the jaw bones and the gums, like periodontal surgery, implant placement, extraction, anything we are involving the teeth and the periapical area, periodontal area, that becomes a dentoalveolar surgery. These infections in this area after the surgery, after dentoalveolar surgeries, are uncommon, and their incidence is not reduced by surgical antibiotic prophylaxis. By giving one dose of antibiotics before the surgical treatment, we cannot reduce the incidence. They can happen sometimes, but these are uncommon. What are the signs and symptoms of post-operative odontogenic infections? First thing we find is signs of cellulitis adjacent to the surgical site. Right, wherever we did, there will be cellulitis in that area, like swelling will be there, tenderness will be there, redness will be there. Fluctuant surgical site, the surgical site itself also has an abscess like fluctuant swelling, purulent discharge coming from the surgical site, foul taste will be coming, bad taste will be coming, pain and swelling that is worsening and not improving 4 days after surgery. This is also another sign. We have to remember all these things. What are the signs of the post surgical infection, right? And signs of severe local or systemic conditions like BAB, swelling of trismus, swelling of the floor of the mouth or neck, difficulty in swallowing, difficulty in breathing, pallor, sweating, tachycardia, temperature above or 38 degrees or below 36 degrees centigrade. Before diagnosing a post-operative odontogenic infection, we have to exclude post-surgical inflammation. Whether it is a normal inflammation which happens whenever we do surgery, that usually resolves after 3 days, and alveolar osteitis or dry socket after a tooth extraction. If a patient has profound immunocompromised condition, then we have to contact their medical practitioner for a treatment plan, because they are at the risk of complications from the infection. Because for them, then the spread of infection will be faster and there will be sepsis, complication of the infection, sepsis, or a further dental procedure. Like in future, if they do dental procedure, like bleeding may be increased. For them, the risk of complications will be more. If a postoperative odontogenic infection is associated with severe local or systemic signs, urgent management is given, like we read before. They need to be referred to hospital urgently, and immediate treatment will be necessary. If the management of the postoperative odontogenic infection without severe local or systemic signs, what does it include? First, we have to use regular use of antiseptic mouthwash, wash out and debride any debris in the socket, drainage and culture of the purulent discharge if feasible, and oral antibiotics are needed because there is a infection is spread and complete drainage is not possible. If antibiotic susceptibility tests are out, then we can give antibiotic accordingly. But if these are not out, then what we have to do? We have to give empirical therapy, addressing the source of infection. Why this infection has come? First of all, we have to see that whether we didn't remove any tooth fragment or root fragment which is infectious, which has remained inside the jaw, that could be a source of infection, right? It can be demonstrated in the X-ray. We have to take X-ray also and check. Analgesia and rehydration therapy. These are all the important treatment aspects of the post-operative odontogenic infections. Next, coming to our next chapter, oral mucosal diseases. This is a very important thing in pertaining to the ADC exam also, and also pertaining to the general management of the patients in our clinic also. This chapter is very important. This book is like a gold mine. Right, gold mine for anybody, especially for the people who are preparing for the ADC exams, Australian Dental Council exams. This book is another gold mine which will help you a lot in passing the exam. Other than that, normal people who are not giving any exam also, they can watch through these videos so that this will help in the better management of the patient. Oral mucosal lesions are common. First sentence they gave is oral mucosal lesions are very common. They may result from physiological changes because of the normal changes in the body, or they might be a local disease or a skin condition with oral features as an adverse reaction, or a systemic disease, adverse drug reaction, or a systemic disease like gastrointestinal disease. Anything can show its features in the oral cavity. That is why oral mucosal lesions are common, result from the physiological normal bodily changes, local disease, allergic reactions, skin condition showing oral features, adverse drug reactions, or systemic diseases. Successful management of an oral mucosal lesion requires accurate diagnosis. First, we have to know what is the condition to treat it successfully. Assessing an oral mucosal lesions involve taking full patient history, including medication history. We have to take all the history. If at all you see any mucosal lesion, we have to take history. Performing a thorough extraoral and intraoral examination and using diagnostic investigations if appropriate. First, we have to take history and perform a thorough extraoral and intraoral examination and using diagnostic investigations if appropriate. We have to ask the patient about the duration of the lesion, from when that they observe that lesion, precipitating factors, what have actually caused it, did something happened around that time, any like trauma from chewing gums or burns from the hot drinks, any symptoms are present, right? These are all the questions we have to ask in the history. Duration of the swell, duration of the lesion, precipitating factor, what actually caused it, and any symptoms are there, exacerbating and relieving factors, what is increasing or anything decreasing these lesions, any other changes that patients associated with the lesion. We have to ask the patient about all these questions. These are very, very important questions. Whenever we see a oral mucosal lesion, we have to ask from when did they see? Are they having any symptoms? Anything improves or reduce the lesion? What are the precipitating factors and any other changes the patient noticed along with the lesion. Always consider oral cancer as possible diagnosis, particularly in patients with risk factor for oral cancer. And see when to refer a patient to oral mucosal disease for symptoms and signs that warrant specialist referral for investigations. Right, whatever oral lesion we saw, we have to first consider oral cancer as a possible diagnosis. Because if we assume the worst, then we'll know when to refer or who to refer, we can assess. Particularly in patients with risk factor for oral cancer. For suppose they're having a habit of smoking or alcohol, drinking, family history is there. That is why taking history is very important. Observing the lesion is also very important. The following conditions can be managed in general dental practice, provided there are no red flags or features that may indicate non-malignant condition warranting referral. What are those conditions? Mild recurrent aphthous ulcerative disease, not severe but mild. Traumatic ulcers we can manage. Mild aphthous ulcer, traumatic ulcers, oral candidiasis, provided it is not recurrent or persistent. Right? If the patient gives the history like this has happened also before, that means there is a recurrent oral candidiasis. Or if the patient says that it is persistent from long time despite doing anything. Only in those cases, if it is so, then we have to refer. If not, if it is the first time, then we can manage oral candidiasis as well. Angular cheilitis, right? We can manage that as well. Oral mucocutaneous viral infections. What are the viral infections? Herpes simplex virus, herpes angina, hand, foot, and mouth disease, herpes zoster, and mild dry mouth. If the dry mouth is mild, that also we can manage. Oral mucositis we can manage. Amalgam tattoo we can manage. Geographic tongue, hairy tongue, physiologic oral pigmentation. These are all the conditions which we can manage in the general dental practice. Some causes of oral mucosal discolorations are physiological, not always pathological. Some causes can be physiological as well. So we have to see what are the physiological causes of the oral mucosal lesions. These include Fordyce spots. Fordyce spots are basically ectopic sebaceous glands. Sebaceous glands are supposed to be found in the skin only, but sometimes in some patients, these sebaceous glands can also be found in the oral cavity. They appear like yellow spots. So these lesions are the physiological discolorations, and leukedema. These do not require active management. Right? See, these are the Fordyce spots, yellow color spots. Normally, these are oil producing spots which are present in the skin, but sometimes they can be seen in the oral cavity. They do not require any treatment. Leukedema is a white opalescent of buccal mucosa visible only when the mucosa is relaxed, not when stretched. So we have to stretch and see. It is seen more commonly in people with dark skin or people who smoke. These people also will have the leukedema that doesn't require any active treatment. Now, when to refer a patient with oral mucosal diseases? Referral criteria aim to promote early investigations of oral mucosal diseases. Why we have to refer the patient? Because to promote early investigations of disease associated with significant morbidity and mortality. If the lesion or if the condition is associated with severe morbidity and mortality, early referral is always utmost important, particularly oral cancer and other potentially malignant disorders. That is why we have to promote early investigations and early referral. Early referral to an appropriate specialist is required. When is it required? When there are red flag features that may indicate oral cancer. If the patient has any red flag features that may indicate oral cancer, we'll discuss down in this table, or if the diagnosis is not clear, or if the patient has not responded to the initial treatment. In either of these three conditions, we have to refer them to a specialist. First thing is when the patient has any red flag features that indicate cancer, that requires early referral to the specialist when the diagnosis is not clear or when the patient does not respond to the initial treatment. One second. Some oral symptoms or signs or features that may indicate non-malignant condition but warrant referral. Though they are not malignant conditions, but they warrant referral in some conditions. We'll discuss about that in the next table as well. But this table is about red flag features that may indicate oral cancer. What are these features? Oral ulcers that have lasted for more than 2 weeks. Right? If the ulcer lasted for more than 2 weeks, then that is a red flag feature. Pigmented lesions or oral mucosa with features that may be symptoms or signs of melanoma. Pigmented lesions in the oral cavity indicating the melanoma, or red, white, or red and white mixed oral mucosal lesions of unknown origin. Leukoplakia, erythroplakia, or with high risk features. If the red and white lesions are unknown in origin, we don't know what caused them, or if there are high risk features. What are the high risk features of that lesions? Induration, when the swelling is indurated, ulceration around rolled margins, and fixation to the underlying tissues. When the borders are indurated, when it is sunken into that area, ulceration will be there, fixation to the underlying tissues will be there, rolled out margins will be there. Lesions at high risk site, lateral tongue and the floor of the mouth. These are the features, high risk features. And then facial or oral paresthesia. If the patient says that he's having facial or oral paresthesia, that is another indication. Persistent oral mucosal discomfort with no obvious cause. We can't find the cause, but the patient will continuously have the oral mucosal discomfort. Something is going on in the mouth. The lumps or swellings, including lymphadenopathy. When we examine the patient extraorally, we can see the lymph glands. Swelling, pain, or blockade of any salivary gland, suggestive of salivary gland disease. For common cause, there are different causes, but these could be the reason for the early referral, right? Potential causes of salivary gland swelling, there are different reasons. Oral cancer must be excluded, but non-malignant causes of persistent ulcer to consider include syphilitic canker. Right? This is not malignant, but there is a chance that it resembles cancer, which is called as syphilis. Syphilitic cancer is a non-malignant cause of persistent ulcer. That is why they said this is the NB1 indication. That note is oral cancer must be excluded. But first we have to exclude oral cancer, but non-malignant causes of persistent ulcer to consider include syphilitic canker. We have to exclude oral cancer, of course, but other possible cause which is with persistent ulcer is oral syphilis. So now what are the red flag features that may indicate oral cancer? First thing is persistent swelling, which is present for more than 2 weeks. Pigmented lesions of the oral cavity, which includes a sign of melanoma. Signs and symptoms of melanoma, red, white, and red and white lesions which are of unknown origin or with features of high risk features such as induration, ulceration with rolled margins, right? Fixation to the underlying tissues and lesions in the high risk site. Paresthesia, facial or oral paresthesia, persistent discomfort without any obvious cause, and lumps or swelling, including lymphadenopathy, swelling, pain, or blockade of a salivary gland suggestive of salivary gland disease. Next, what are the features that may indicate a non-malignant condition but warranting specialist referral? Earlier, we discussed about the malignant condition, risk of oral cancer, but now these are non-malignant condition, but they still warrant specialist referral. What are these? Suspected allergy or adverse reactions to dental materials, lichenoid reaction, right? Oral ulcers that recur. Oral ulcers that persist for more than 2 weeks are red flag features. But oral ulcers that recur is not a malignant condition, but it needs a specialist referral because something might be happening because of that is why there is recurrence of the oral ulcers and non-traumatic ulcers in children, right? If they are not traumatic ulcers can happen in children if they bite on something, that can happen. But if a non-traumatic ulcer happens in children, then that is a condition which indicates warrants specialist referral. Dry mouth that is not adequately relieved with over-the-counter products. Earlier, we said in the red flag features, swelling, pain, or blockage of a salivary gland. Not everything. Swelling, pain, or blockage of a salivary gland suggestive of salivary gland disease. That is a risk condition. We have to understand why it is caused. But dry mouth that is not adequately relieved with over-the-counter products and non-pharmacological methods like drinking water, continuous hydration therapy of 1.5 liters of water, bicarbonate mouthwashes, oral lubricant, chewing, sugar-free chewing gums. These conditions, if they are not relieved, then we have to refer to a specialist. Suspected oral manifestations of undiagnosed systemic diseases. Some lesions could be related to the systemic conditions which are going on in the body. So, suspected oral manifestations of undiagnostic systemic diseases, such as syphilis, can appear in the oral cavity, usually appears as ulcers. Sign vary with the disease. We'll read about syphilis also. And Behcet syndrome, appearing as tender, ovoid oral mucosal ulcers with red halo and a history of eye inflammation and genital ulcers. Behcet syndrome includes tender, ovoid oral mucosal ulcers. They will be very tender, oval in shape, and mucosal ulcers with a red halo around them, right? And a history of eye inflammation and genital ulcers. HIV, manifesting as a condition such as oral hairy leukoplakia or chronic oral or oropharyngeal cancer. It is a non-malignant condition, but we still need to refer to the specialist. Inflammatory bowel disease usually appear as linear oral ulcers or tissue tags or a cobblestone appearance of the buccal mucosa. Inflammatory bowel disease usually appears like that, like a linear ulcer, linear oral ulcers, and oral tissue tags or a cobblestone appearance. Lichen planus, usually appearing as white striations on the oral mucosa. And pemphigus and pemphigoid usually appearing as ulcers or blisters with peeling of the oral tissues. Like a desquamation, the peeling of the oral tissues will happen. Pemphigoid and pemphigus, right? These are all the conditions which are non-malignant conditions but require specialist referral. Oral lesions in patients who have immunocompromised for cause, we have to search for the known to have immunocompromise for the causes for the profound immunocompromise. We have to see what is their immunocompromise and contact their specialist medical team. So these are all the conditions we have to keep in mind. What are the red flag features? What are the features that indicate that may indicate a non-malignant condition but specialist referral? What are those conditions? Lichenoid reactions, allergic to dental materials, oral ulcers that recur, and non-traumatic ulcers in kidney, dry mouth not treated by the over-the-counter products. Suspected oral mucosal lesions of a systemic disease such as syphilis can appear as a canker. Behcet syndrome can appear as oral ulcers with red halo. HIV can appear, HIV which is going on in a body can appear as oral hairy leukoplakia, chronic hypoplastic candidiasis. Inflammatory bowel disease usually appears as a linear oral ulcer, tissue tags, or cobblestone appearance of the buccal mucosa. Lichen planus appearing as white striations. Pemphigus and pemphigoid usually appear as ulcers and blisters with the peeling of oral tissues. That is called as Nikolsky's sign. When we touch that area, the skin will be peeled and coming out. Oral lesions in patients known to have immunocompromise. If they are known to have immunocompromise, then we have to check for the causes of the profound immunocompromised condition. Oral hairy leukoplakia is associated with Epstein-Barr virus infection and is seen in patients who are having immunocompromise. This viral attack only happens when the patient is severely immunocompromised. It is distinct from oral leukoplakia, which is an oral potentially malignant disorder. For images of oral leukoplakia, we'll see in this website. Oral hairy leukoplakia and chronic candidiasis are indicators for HIV testing. If the patient is having oral hairy leukoplakia or chronic candidiasis, we have to send them to HIV testing. Indicator conditions for HIV testings are conditions that are seen in people with HIV infection, conditions that share a transmission route of HIV, or condition in which management is altered in people with HIV infection. If oral hairy leukoplakia or chronic candidiasis is identified, HIV testing should be offered by the patient's medical practitioner, regardless of whether the patient has behavioral or epidemiological risk factors for HIV infection. Though they might not have any risk factors for getting HIV infection, but still HIV testing should be done. An oral medicine specialist is an appropriate specialist to diagnose and manage oral mucosal disease, but may not be accessible. An oral surgeon, dermatologist, or otolaryngologist, otorhinolaryngologist are other options. First choice is oral medicine specialist, if not oral surgeon or dermatologist or otorhinolaryngologist are other options, right? Next comes oral cancer. Oral cancer is associated with significant morbidity, mortality. Everybody knows that early presentations of oral cancers are usually asymptomatic. Initially, oral cancers are asymptomatic, whereas late presentations include pain, discomfort, reduced mobility of the tongue, and increased mobility of the teeth or inability to wear dentures. Early, it might be asymptomatic, but later on, it becomes painful. There'll be discomfort. Mobility of the tongue will be reduced, but teeth will be more mobile or inability to wear dentures. Oral cancer varies in appearance and can mimic many other oral mucosal diseases. They can mimic any other oral mucosal disease. So, early specialist referral is required for investigation and biopsy of any suspicious lesion. Evaluation follow the approach in the assessment of oral mucosal disease, which we discussed. Any suspicious lesions need early specialist referral for investigation and biopsy. First big thing, oral cancer, we have to discuss is oral squamous cell carcinoma. It is the most common oral malignancy. Oral squamous cell carcinoma can affect any part of the oral mucosa. However, it most commonly occurs in the lateral border of the tongue, the floor of the mouth or the gingiva. Usually occurs in the high risk site, like lateral border of the tongue, floor of the mouth, or gingiva. Risk factors for oral squamous cell carcinoma. What are the risk factors which place the patient at higher risk? Advanced age and male gender, males, smoking or tobacco use, alcohol use, known other oral potentially malignant disorders like oral submucous fibrosis, leukoplakia, erythroplakia, infection by oncogenic viruses. Certain viruses are known to cause cancer, like human papilloma virus. Related head and neck cancer is an indicator for HIV testing. Earlier we described, right? Oral hairy leukoplakia or chronic candidiasis is one risk factor which patient has to undergo HIV testing. And this human papilloma virus infection also requires HIV testing. If HPV related head and neck cancer is identified, HIV testing should be offered by the treating medical practitioner, regardless of whether patient has behavioral or epidemiological risk factor. That doesn't matter whether the patient is at risk or not, it doesn't matter. They have to get it checked. Personal or family history of squamous cell carcinoma of head and neck, history of cancer therapy. Refer patients with a suspicious lesion following head and neck cancer treatment for investigation to exclude cancer recurrence or assess for a new primary cancer. That is why when there is history of cancer therapy, they are at risk. Prolonged immunosuppression, they are at risk. Chewing erica nut alone or in a betel quid mixture. What they usually chew in remote Indian villages, we can see, right? People chewing to betel nut or quid mixture. And sunlight, excessive sun exposure, a risk factor for lip cancer. The incidence of oral squamous cell carcinoma is rising in young female patients without any typical risk factors. Nowadays, we find that it is increased in the young female patients. Here we said males are the risk factors and advanced age is the risk factor. But even in the younger female patients, now the incidence of squamous cell carcinoma is increasing even without the presence of typical risk factors. Genetic susceptibility, sometimes genetics plays a role, environment plays a role, occupation plays a role, and diet may also contribute to the development of oral squamous cell carcinoma. See, these are the lesions. We see that oral squamous cell carcinoma, the lateral border of the tongue, on the inferior surface of the ventral surface of the tongue. Here we can see in the left mandibular alveolus bone region. Cancers originating from salivary glands and supporting non-epithelial tissues are less common than OSCC. So cancers from the salivary glands and supporting non-epithelial tissues is less common. Metastatic cancers to oral soft tissues and jaw bones commonly present as lumps on the tongue and gingiva. They are present as if the metastatic cancers are there in the oral cavity. From the cancers from other place have migrated to the oral cavity, then they commonly appear as lumps on tongue and gingiva. We have to check for the tongue lumps also. They originate from the primary malignancies in breast, prostate, kidney, and lungs. These are the primary malignancies which cause metastatic lesions in the oral cavity, mainly lumps on the tongue and gingiva. Other malignancies that can present in the oral cavity include leukemia, lymphoma, and rarely oral mucosal melanoma. Leukemia, lymphoma, and oral mucosal melanoma. Excuse me. Who should perform the biopsy? The treating specialist should perform the biopsy. We discussed about biopsy. Where did we discuss about biopsy? See, early investigations, early referral for specialist investigations and biopsy. Biopsy is usually done by the specialist. If a delay in specialist review is expected, seek expert advice on biopsy technique. A punch biopsy is not appropriate. We can't take a punch biopsy. We have to take an excisional biopsy with the normal tissue, surrounding normal tissue for comparison also. Right? Punch biopsy will not be giving any proper results. That is why you have to take a specialist advice and do the biopsy technique if early referral is not possible. Indicator conditions for HIV testings are the conditions that seen in people with HIV infection, mostly undiagnosed HIV infection, and conditions that share a transmission of HIV virus, that is sexually transmitted diseases, or conditions in which management is altered in people. So these are the conditions which require HIV testing, right? For the people, if the lesions are so that they indicate an undiagnosed infection, or any lesions, any condition that share a transmission route with HIV, like sexually transmittable diseases like syphilis, or conditions in which management is altered in people with HIV, like tuberculosis. These conditions requires early HIV testing. What are the oral potentially malignant disorders? Oral potentially malignant disorders are conditions in which a field change increases lifetime cancer risk in the tissues of lip and mouth. If there is any change in the surrounding conditions, then these pre-malignant conditions lead to malignancies. Although most lesions do not progress to cancer. Though they are called potentially malignant conditions, they don't usually progress to cancer, but there is a possibility. These disorders include oral leukoplakia. First thing is oral leukoplakia, proliferative verrucous leukoplakia, in which lesions have irregular rough appearance, oral erythroplakia, actinic cheilitis due to the sunlight, keratosis, ultraviolet keratosis causing atrophy, erosion, and white patches on the lips, oral lichen planus, OSMF, palatal lesions in reverse smokers, oral lupus erythematosus, autoimmune lesion in the lip and inside of the mouth, presenting as red areas with a white surrounding striations. Oral lupus erythematosus. Dyskeratosis congenita, oral lichenoid lesions, and oral graft versus host disease. Lesion similar to lichen planus after a bone marrow transport from a donor. Any suspicious lesion needs early specialist referral for investigations. Field change is a high prevalence of pre-malignant genetic changes in a tissue. That is what is called as field change. Reverse smoking involves placing the lit end of the cigarette in the mouth before inhaling. It causes red and white patches on the hard palates, often stained with nicotine. That is it for today. Tomorrow we can discuss the further chapters. Thank you so much. Bye.